Good evening and welcome to our live call-in show, monthly second Tuesday of each month from Cardiovascular Institute of South at Opelousas General Hospital. Tonight's topic, as all of you have seen, is a discussion about a breakdown of new cardiovascular horizons or premier peripheral vascular interventional program that took place in New Orleans that we do annually. And the founder of the program, as well as Dr. Walker here, who's a regular on my show, who most of my audience is familiar. And then I also have Dr. Nick Cavros, who joined us recently and is operating at Lafayette General Hospital. Started off, welcome both to the program. And I want you to start off by shedding some light on the founding of the Cardiovascular Horizons meeting. What is the thought process behind when you founded this meeting years ago? What is the purpose of this meeting in advancing the whole arena of peripheral vascular disease?
Sure. This is meant to promote technique and technology of how to deal with peripheral vascular disease, both arterial and venous disease. These represent huge health problems worldwide. In fact, this is one of the greatest problems affecting people throughout the world. It's one of the leading causes of stroke, of loss of limb, of hypertension, and many of the other maladies which have caused great problems throughout time. And there have been great breakthroughs in how we treat this. So what the conference is meant to do is to teach and to interact with others on what are the best techniques, as well as to discuss new or evolving techniques which are either just recently been released in the United States, or in certain cases, things which are not yet even released in the United States, but are available in other countries at this point, so that practitioners can learn what is coming, what is out there now, and better improve the care of these patients.
Right, very much. Ever since I finished up my training with all of you years ago, and I left and started off working in the arena of peripheral vascular disease in Shreveport, every year I continued to come down to the conference and to be in touch. And at that time, I've also had the latitude of attending other conferences. But time and again, we came down to Cardiovascular Horizons because of the way it was conducted, because of the all-inclusive nature of it. Not only was it addressing the needs of the interventionalists and the interventional community, it was also addressed in how to build about physicians and internists and how a guy at a grassroots level could diagnose peripheral vascular disease, how to channelize that, how to get that patient taken care of, and also with your vision. And at that time, Dr. Ali's involvement as well, a lot of work was done in involving podiatrists, and what an integral part they played in recognizing and getting these patients taken care of. And at this stage, Nick, I want to ask you to make a few comments about the emerging epidemic of peripheral arterial disease. When we were training, PAD was not in the national lingo, and we were all talking about still heart attacks and strokes. But now it has become a commonplace to see this PAD, and the nation has, the campaigns have raised the awareness of the public. And why is it, you think, that at this juncture that PAD has become such an important part?
Well, I think PAD was, not recognized for so long, and it was treated much like that relative that we have, that we invite over for Thanksgiving, and we don't really want him there, but he's got to be there because, he's our relative, and we hope he eats his meal and then goes home very quickly. And that's kind of like how peripheral arterial disease was treated in the past. We kind of got to it when it was at the end stages, and then shipped him off to somebody, to, a vascular specialist or vascular surgeon to deal with it, and then, our eyes were off of it. Now we understand a lot more that, it's not the compartmentalized approach to medicine where it's a leg, it's a carotid, it's a heart. We know now that, the disease is one, and it affects all different areas of the body. And that's why it's gained so much critical importance now to diagnose it early, because it's a marker not only of leg problems or arm problems or so forth, but it's also a marker of heart attack, stroke. If you find plaque somewhere in the leg, that patient automatically has an increased risk of a heart attack and a stroke. So it's critically important that we identify this disease in early stages.
Absolutely, Dr. Walker. Certainly, I'm sure you have a thing or two to say about this epidemic.
Sure. If we believe some of the recent data from Mary Yost and the SAGE group, the incidence of this in just the United States may be greater than 30 million people. That's the potential incidence of peripheral arterial disease. That doesn't even include the venous side. And there may be as many as 1.2 million Americans affected by critical limb ischemia, which is what causes people to lose limbs if untreated. Now, the reason early on we put all of the disciplines together, family medicine, podiatry, wound healing, diabetology, interventional cardiology, radiology, surgery, all of the disciplines, is because they all need to work together to have the best outcomes in these patients. So what we were trying to do is fill in the gaps. All of us read our various trade journals. We may read the cardiology journal or the vascular surgery journal, but all of those have a given slant. The purpose of the meeting was to get rid of all of those slants and do global care of the patient.
That's exactly right. Well, historically, all along, most of the training institutions, even the larger Ivy League status training institutions, have had the slant. Cardiologists did their share, and they were confined to cardiology. And vascular surgeons, when we were training, when we were in med school, we were taught to refer these, and which was a good thing. At the time, the evolution of medicine was such that all these things were operated upon, including the carotid disease. We would do diagnostic angiography many years ago and would send it to surgery religiously. But as time went by, as coronary artery disease care evolved, from medicines to bypass surgery to balloon angioplasty and stenting, so did peripheral arterial disease. What used to be endarterectomy and extensive bypass surgeries has evolved into much more sophisticated endovascular angioplasty, and then on led to different various forms of atherectomy, debulking, and even some with the assistance of stenting. So with that said, within cardiovascular horizons, I've seen the evolution of the meeting. And now lately, we have gone, you mentioned the word critical limb ischemia, which is a complex term for some of the audience, but basically to break it down, critical limb ischemia, we are talking about ulceration or impending jeopardy of typically a lower extremity because of inadequacy in blood flow. Most commonly, we think of as diabetics having an ulcer and it never healing, and then eventually you try to do some wound care. But without the key element of the blood getting there, the limb is thought to be at critical limb ischemia, or CLI. So that is the word we'll be repeating during this discussion. So I want the audience to be familiar with that term. With that, Dr. Walker, where did the whole involvement of critical limb ischemia come in? How did cardiologists who were taking care of the heart get so deep involved, taking care of arteries all the way down to the toes? And what kind of impact, besides saving the leg, what kind of impact does it have on the morbidity and mortality of the overall patient?
Sure. The critical limb ischemia, which really is a term which means rest pain, ulceration, or gangrene, as you mentioned before, has been shown by Wolf to result in, if untreated, amputation in more than 70% of those patients. Now, if we look at the anatomy of critical limb ischemia, the most common anatomy of critical limb ischemia is for there to be blockages of the vessels below the knee. There may also be concomitant inflow disease, so the bigger vessels above the knee may also have blockages, but almost always it's a major element of blockages below the knee, and more commonly than not, these patients have diabetes or they're smokers, and they tend to be older. Well, the reason that cardiologists got into this were many. One, these patients are often very critically ill, and they can't have surgery because they're so critically ill with their heart disease or their carotid disease. Secondly, the vessels below the knee are roughly the same size as heart vessels. And so the devices that we use in the heart work very nicely there. Thirdly, this tends to be an area where small wires tend to be better than bigger wires. And again, this is small wire skill sets or things which the cardiologist had. And then finally, cardiologists had to send many of these people off to urgent bypass surgery of the heart or other things, and needed to be able to open up blood flow to the legs so that when the surgeons had to harvest veins out of the legs, those vein harvest wounds would heal. So there are many reasons cardiologists got involved from that perspective, on top of which cardiologists, once a patient is treated, has to be rehabbed. If you can't walk, you can't build up your exercise capacity. So across the board, this was a natural marriage between cardiologists and critical limb ischemia.
Absolutely. That is really, I mean, if you look at the many, this is the first time among all the conferences that we have attended, this is one among the very first conferences. Others have followed our lead on that in putting a critical limb ischemia summit and bring specialists from different, including surgeons and radiologists and cardiologists like us from various portions of the world to get involved and do both live cases as well as give lectures about treating and approaching this critical limb ischemia. And, and surgery, as you pointed out, surgery is not an option when you have arteries about this big and they're really eaten up, diffusely diseased. Surgery may not be the best option even in the hands of the best surgeons. And there is limited amount of skill across the nation in salvaging these so-called critical limb ischemia patients. So thereby goes our conference involvement. The same token, Nick, what other areas did you find with your involvement in the meeting in Horizons? What are some of the other areas besides, I know you chaired the section with renal and mesenteric arterial disease, and I was involved in the carotid disease. So what do you think about our involvement as vascular specialists in all the vascular beds from head to toe?
Yeah, sure. Again, we are cardiovascular disease specialists, so our attention is from head to toe. We have to give mind to every single point of the vessels of the arteries in the body and the veins. So one of the very interesting topics was the renal and mesenteric area. The renal arteries are the ones that feed the kidneys, and the mesenteric arteries are the arteries that feed the gut and the stomach. And there are very, very exciting developments in both those areas. From the kidney standpoint, we know that a certain percentage of high blood pressure is attributable to narrowing of the kidney arteries. And we have known for some time that appropriate treatment of those arteries can lead to either a decrease in the amount of medications you may need or better control of blood pressure on your current medications. But really a very, very exciting development was one of the new devices that are being used now in Europe and have been trialed and are being trialed here in the United States with a very slender catheter that goes inside the kidney artery and ablates or affects the nerves that feed the kidney, because we know that the nerves that feed the kidney do have something to do with the control of blood pressure. And one of the interesting latest clinical trials with the results mainly out of Europe now have shown that this catheter can actually really substantially reduce blood pressure permanently without any other treatment, getting a lowering of blood pressure of almost 30 millimeters mercury. And that could be a tremendous, tremendous boon to our patients who a lot of times are on multiple drugs, especially for those patients who have what we call resistant hypertension, resistant blood pressure that is, very difficult to control even on 4 and 5 medications. So that's really one of the most exciting, events that we saw.
Absolutely, that is